Hello, everybody, and welcome to this ICH webinar. My name is Pashna Munshi. I'm a stem cell transplant physician at the Abramson Cancer Center of the University of Pennsylvania in Philadelphia. I recently joined the University of Pennsylvania about a few months ago last year. Prior to that, I was at Georgetown University for about over 7.5 years, where I was the associate director of the stem cell transplant and cell therapy program. It's been quite an interesting journey. My interest and expertise is outcomes and improving patient outcomes in the older population for those patients receiving stem cell transplant and cell therapies. So thank you for joining us today. Here are my disclosures. I thought, given that we have about 55 minutes for this conversation, I thought I'd go over some of the aging demographics, including biology of aging, and then a little brief overview on the history of specifically cancer and aging, and then lead you to some of the frailty assessments, particularly the research that is done currently at UPenn and some other programs, and then leave you with some thoughts for future directions. Now, the WHO, World Health Organization, is also very involved, and they have an agenda in this current decade to overcome effects of aging and to bridge the gap between disparities for the aging population. And these are some of the facts that I've picked up from the WHO website, where they declare that the pace of population aging is really much faster than the past. In 2020, the number of people who are older than 60 years outnumbered children who are younger than 5 years. And between 2015 and 2050, the proportion of the world's population over 60 years will double from 12% to 22%. So in the years gone by, centuries ago, age was considered a curse. Through ancient times, they felt that if you got old, age itself was a disease, and this was declared by the Roman playwright Terentius. However, in 106 BC, the Roman politician Cicero, who was also a lawyer and a great orator of his time, wrote an essay on old age, and he contended that age was a curse. And he said that we have to fight against aging as we do against a disease. And then since then, there has been some dramatic responses to how we view aging and knowing that it is vulnerable to disease. So this brings me to showing you some of the prevalent diseases that happen as people get older with chronic conditions, the leading chronic conditions being arthritis and heart disease. And then finally, cancer and diabetes. As you can see, it peaks as people get into their 60s and 70s and continues to rise. However, what we have noticed is that in the early 20th century, old was considered anybody who's 65 years and older. And this was mostly because of the establishment of the Social Securities Administration Act in 1935, where at that age, people were allowed to get Social Security benefits in the United States. In 1935, the average American life expectancy was 61 years. So you can imagine that most people did not collect this Social Security if they did not get to be 65 years and older, because they were dying from conditions like heart disease, cardiovascular problems, hypertension, diabetes, etc. And cancer really was not in the forefront or probably underdiagnosed at that time. But here you can see that now cancer statistics, even in older people aged 85 years and older, as we call the oldest old, continues to rise, and it continues to peak well over the age of 60, regardless of the gender of the patients. And therefore, what we're dealing with now is, as we are getting better with the health care we give our older patients, we're seeing more and more prevalence of cancer survivors in the United States. And I like this term silver tsunami, because by 2040, the number of cancer survivors older than 75 years is going to be much more than those of their younger counterparts, as this graph is showing. Now, specifically looking at how our transplant survivors are doing and the number of patients going through transplant through the CIBMTR, which is the Center of International Blood and Marrow Transplant Research, you could see that in 2005, recipients older than 70 years were about 1%, while in 2021, they're about 10%. So clearly, those patients were getting more and more confident in doing transplants for older patients, and we're seeing that trend as well. Now, there are many advances associated with transplantation, where you again continue to see the number of transplants increasing, again showing that the percentage of these transplants in patients 76 years and older went from 0.03% in 2000s all the way to 0.58% in 2017 and 2019, again from the CIBMTR data. Now, despite us doing transplants effectively, Anthony Sung and colleagues recently showed in this year's publication that septuagenarians, or people older than 70, have an inferior survival of transplant. And this was because of non-relapse mortality. So you can see the graph, Kaplan markers on the left, where the red line, which is 70 years and older, there has an increased cumulative incidence of non-relapse mortality compared to 60 to 69 years. And this is not related to relapse. And you could see that on the right, the relapse by age curves are not statistically significant. However, this does impact overall survival. And so people older than 70 years really have poor survival compared to their younger counterparts. Even somebody who's 65 years, they do have a poor survival compared to them after transplant. So there was a group that certainly continued to investigate this, and they broke up these older patients into their frailty assessments. And I'll talk about this a little bit more in detail. But initially, just so you understand, the groups were divided into fit, pre-frail, and frailty. And so those patients who were frail or pre-frail, as seen by the blue and red line, really had a worse non-relapse mortality compared to those who were fit, but it wasn't quite statistically significant. However, what was significant is the difference in overall survival, where the fit patients really had a better overall survival compared to those who were pre-frail and frail. And this again goes to show that post-transplant, the reasons of overall survival and inability to handle treatments really could be because of the frailty problem. And so why do some older patients do worse after transplant than the others? And you can see that over here, both these gentlemen had their pictures taken probably around 75, 76 years of age. And you can definitely tell how one of them is fit and the other doesn't look as fit. And so can we choose to age differently? And why is that? Now, we all know that there are intrinsic changes that happen in our body that lead to cellular aging all the way from pre-birth, infancy to adulthood. And this results in a cyclical state in our bodies, leading from inflammation and cell division, causing telomere attrition and shortening with each division. And then furthermore, if there are epigenetic alterations and mutations that can happen, can result in loss of proteostasis and stem cell exhaustion. On the bottom right, I'd like to show you how there is relative abundance in ribosomes, but with age in this preclinical data in worms, that there is decrease in the ribosomes in both the cytosolic and mitochondrial structures, leading to loss of proteostasis as with age. And then there's also a mitochondrial dysfunction and a cyclical state that's set up like a vicious cycle, where aging has more production of reactive oxygen species and furthermore more oxidative damage. And so when there is, in general, changes in the biology and changes in the balance between injury and repair, this is where we have problems with organ integrity and how people may be susceptible to age. Now, in order to understand this, one might say, where is the research? And it took a while for cancer and aging research to come into the forefront, for us to realize what is the biology of aging and how does it impact cancer? How does cancer develop in older age groups compared to younger age groups, and what can we do about it? So here I thought this was interesting that I found in ASCO, one of the ASCO publications in the history of geriatric oncology, divided into 3 time periods. In the prehistory time period, you can see that age was used as a prognostic and predictive marker, and patients who were 65 years and older were excluded from clinical trials. In the second time period, there was a big boom in cancer and aging research. There was realization that there's increased cancer prevalence in aging, and then there was a lot of reliable information that was collected with risk-benefit treatment. Starting with the institution of the National Institutes of Health. This was established in 1887, and then finally the American Association of Cancer Research, and in 1937, the National Cancer Institute in the United States was established. This finally led on to other societies through the 1940s and 1960s. 1964, the American Society of Clinical Oncology, as you know, as ASCO, that just had its big meeting this past weekend. And then finally in 75, European Society of Medical Oncology. And it was not until the 2000s where leading experts got together to develop this International Society of Geriatric Oncology called CEOG, that the current era of geriatric oncology is now prevalent in, where there is training, research, guidelines, diagnostic toolkits, etc., that's really advancing at a rapid pace. But we're still just 20 years young when you look at the timeline. So this leads us to the development of comprehensive geriatric assessments. On the left, I've given you a basic definition that these are evidence-based, they're multidimensional, they have to be interdisciplinary with medical, psychological, and functional involvements, and they're aimed at developing an integrated plan for that patient's treatment and care. And in that, I wanted to show you how nicely it integrates into the determinants of health model. This was developed in the 1990s, but again, we're a little bit behind in how we utilize this in our clinical practice on a day-to-day basis, where we do involve our social workers to come and talk to our patients, but we don't really sit and strategically evaluate the social determinants of health that patients have and can impact their outcomes. In that, what I mean by they have individual lifestyle factors, you have a middle circle of their social and community networks and how they live in that wider circle of, environment that affects their outcomes is really important, especially people in middle-income countries and lower-income countries where there's agriculture and food production, there's health disparities, there is problems with education, unemployment, sanitary health, all of that can really impact access to care. And we see that in the United States as well, in rural parts of the country, where a lot of our patients, especially older patients, are denied the care that they should receive. So I like to think of age-friendly care as having 5 important tenets. And one of the first most important tenets to think about in an older patient with cancer is really what matters to the patient, and to understand with one question, what would you like to hear from me today? And it's important to see that sometimes they may tell you, I just want quality of life. And I want to live for another 20 years. And some will say they're guilty and they don't want to involve their family members in all their care that they need. So it's a multi-complexity management, clearly then with a focus on the more practical aspects of their medication, mentation, and finally, mobility. And so when we talk about mobility, I'll talk about frailty, which is today's topic soon enough. And so here you can see the dynamic of how many people are involved in managing older patients, thinking about their physical, psychosocial, and functional environments, and then doing a planned assessment and a personalized care plan. So the components of the comprehensive geriatric assessment not only includes just medical and surgical and social history, but also their functional history along with a full physical assessment. And that brings us to a specific review of systems called the geriatric review of systems. This involves using cognitive screens, understanding their mental health and their mood, asking about their history of falls, their sleep hygiene and sleep patterns, if they're in chronic pain, if they have poor nutrition that leads to muscle wasting and sarcopenia that affects frailty. Certainly, if they have problems with continence, that they're not leaving the home, they are restricted in how far they can go, and so they're not going for their routine walks, or they're socially recluse. All of this can affect the health of that older patient. And certainly polypharmacy is one of the things that we don't really are mindful of, because we're really thinking about cancer and prevention and relapse, etc. So a lot of these components built together into something known as frailty. And frailty was essentially described by Fried and colleagues, and they've done a great job in describing this clinical syndrome, where you could see that there are timelines from death to robust health, and there's a breakdown in the physiological system's integrity with every stressor that the patient is experiencing. So the patient experiences a stressor, and then the stress response dynamics are very fluid over time. Depending on the patient's resilience after these exogenous stressors, they recover, but they get sick again, and then the recovery is even slower, as you can see, with the trough getting deeper and the slope getting even more deep, and then they ultimately become pre-frail. They fall below the standard deviation line and become frail, and ultimately that threshold below which they become frail could be physiologically incompatible with life. So this is a loss of physiological reserves leading to declining integrity. And this was first developed by Fried, Tangen, Walston, who has a geriatric oncologist at Johns Hopkins, and colleagues in the cardiovascular health study in 2001. And this further frailty phenotype was validated by colleagues in women's health and aging studies in 2006. So I'd like to put together this table to show both the cardiovascular health study from 2001 and the women's health and aging study from 2006, and how they use the characteristics of the 5 frailty-defining phenotypic criteria. So the first criteria is weight loss. Those patients who lose about 10 pounds unintentionally in the last year at baseline, then exhaustion, which is a self-reported function. Then number 3 is a low physical activity, which is measured on an activity scale. Then 4 is slowness, depending on their pace at which they walk, about 15 feet. And then weakness, which is measured by a dynamometer by grip strength for both men and women. So this is the frailty defining phenotype using these criteria. And then a single score is developed as an aggregate measure. And then patients are classified as either healthy or robust if they score 0. If they score 1 to 2, then they're pre-frail. And if they score high, 3 to 5, then they're considered frail. And there is always an overlap between patients who have sarcopenia and frailty. So patients who have low muscle mass or loss of skeletal muscle or nutrition, they may not entirely be frail yet, but there's an overlap. And if you combine sarcopenia and problems with nutrition and frailty, then this ultimately leads to slow gait speed, poor balance, and physical function impairment as a whole. And therefore, your frailty assessments also should include the nutritional component to it. So that brings us to some of the research done by my colleague Shannon McCurdy at Penn. Shannon did 2 studies initially looking at the prevalence of frailty in newly diagnosed AML and MDS patients who are older than 60 years. This is the first study for that. And the second, schema B, was looking at transplant patients older than 60 years and their prevalence of frailty. And so these patients underwent frailty assessments at regular intervals of their treatment. This was also done for the heme malignancy patients at pre-transplant and at several months after transplant at regular intervals. And both of these, you could see that there was a prevalence of frailty, much more in patients at diagnosis with AML. They were about 43.4% frail patients and lesser amount of pre-frail patients at this juncture. Clearly, that obviously can also be because acute leukemia makes patients frail. The disease characteristics in itself can do that. So the objective of such a study was to look at overall survival and whether the frailty phenotype was associated with overall survival in this older adult AML population. And these patients had different types of chemotherapy at induction. The high-intensity chemotherapy was defined as the standard 7 and 3 daunorubicin type of therapy with cytarabine and targeted agent, or Vyxeos, which has been approved for older patients. Then intermediate dose like a venetoclax or decitabine with a targeted agent, and then low intensity with just single agent targeted agent or single agent decitabine venetoclax. And what she showed is that the frailty phenotype, meaning patients who are fit, pre-frail, and frail, was associated with age. You could see that older people, you could see that there was more frailty than based on their performance status on the top right. People who had poor performance status, the ones in the blue curve who were more frail had worse performance status. On the bottom right, even with the ELN criteria, with more intermediate and adverse risk in the frail population, as well as the pre-transplant comorbidity score called the SORA score or the HCTCI, notably higher in the frail population with higher scores seen there. And furthermore, this did predict for inferior overall survival in the pre-frail and frail patients. And you could see that the 2-year overall survival was 24% in frail patients versus 43% in the pre-frail patients. And this was significant even at day 100. So the part B, looking at the prevalence of frailty in patients at the time of transplant, more of these patients were pre-frail than frail. Again, given the fact that they probably have a little more time and to recover after the induction therapy, and with cycles of consolidation, maybe they have a chance to get a little more fit at the time of transplant. And we also are a little more firm in our eligibility to take patients to transplant when they're not frail. However, even with transplant, there's an inferior overall survival for those patients who are pre-frail and frail. And you can see that with the left Kaplan-Meier curves all the way to the left. And even regardless of how they divided it up based on the conditioning intensity, which naturally is mostly reduced intensity or non-myeloablative. And when looking at overall survival by age, breaking it down to 60 to 69 years, in those patients, when you divide it up like that, then the curves separate a little bit, and fit people who are 60 to 69 years and older by frailty phenotype, they have a better survival probability than those who are pre-frail and frail, even in this age group. And this frailty assessment calculator is available through the Johns Hopkins Healthcare Solutions. In terms of looking at relapse after transplant, again, on the status of the fit patients, you could see that more of the pie graph, 64% of them are alive after transplant, but frail and pre-frail patients on the middle and the right, you could see that less percentage are alive. There is increase in relapse-related mortality seen by the black part of the pie graph. And on the bottom, you see the Kaplan-Meier curves, where relapse is also prevalent at 2 years in the frail and pre-frail group compared to the fit group. And this also could be a component because post-maintenance strategies, if they've been incorporated, certainly are given more to patients who can tolerate them than those who can't tolerate them. And then in her unpublished work, she continues to show that survival by day 30, as well as by 6 months after transplant, is significantly worse for those patients who are frail compared to those who are pre-frail. And therefore, this findings led to a supervised exercise intervention program at Penn, which is currently ongoing, where we're enrolling patients into 2 cohorts based on their frailty, where they're undergoing prehabilitation or they actually need rehabilitation as they're coming to their transplantation. And so these patients perform self-guided exercises. They have certain timelines and number of times a week that they have to do this. They can do this mostly by themselves, but then they also go to a Penn-based rehabilitation center as per their study protocol. Exercises have to start at a minimum of 1 month before admission for transplant. And then they continue all the way from discharge to day 100, where they focus on strength, they focus on power, as well as endurance. So this brings me to another large frailty scale commonly used, mostly in Canada and in the UK. This is called the Clinical Frailty Scale by Rockwood. And what I think is different here is that it's mostly judgment-based, and it's a tool that specifically includes comorbidity, function, and cognition. It basically ranges in a frailty score from very fit, again, to terminally ill. And the pictures are really just pictorial, mostly just to gauge what the categories are, but not to use the pictures as guidelines to test the patient. So you really have to, the operator has to be very, very astute in determining who's really very fit versus somebody who's well, versus somebody who's managing well until they become vulnerable to mildly frail and severely frail. So I think this requires a little more training and a little more a comfortable approach. Basically, the physician has to be a little more comfortable in delivering this scale. This was a study, a prospective study done in Toronto in Canada at the Princess Margaret Cancer Centre, and they used the Rockwood Frailty Scale as well as the instrumental activities of daily living in their study. They used the timed up and go test, the grip strength, and a patient's self-rated health questionnaire. They also assessed for falls, and then they looked at biological markers of aging with serum albumin and C-reactive protein. It took them about a median time of 5 to 6 minutes, usually performed by the medical doctor, and some were done by the nurse coordinator. So you could see that who the ones in blue were done by the physician, the ones in the orange were done by the nurse coordinator. And this is done at the time of first consultation before the time of transplant. And the only cost that they said they had was to spend on the hand dynamometer, no other recurrent costs. So this was overall, they showed feasibility of this approach, and they had a training cohort and a validation cohort, both showing predictive nature of pre-frail and frailty with overall survival. So again, this is relatively simple enough to do in the clinics by this study. There was another study that I found interesting, and this was the BMT survivor study, which is called the BMTSS. And here they looked at all transplant survivors who were older between 1974 and 2014, who had survived more than 2 years at the University of Alabama in Birmingham, City of Hope in California, and the University of Minnesota. And their analysis only included patients who were pre-frail or fit or non-frail. They did not include those who were frail. And what they saw was they basically compared these survivors with their same-sex biological siblings at that age. They adjusted the age at the survey and for other health conditions. And they saw that there was an increase in survivors who were pre-frail, 77%, compared to their same-sex biological siblings of just 23%. And they made an association of female sex, pre-BMT radiation, smoking, any lack of exercise or anxiety, other chronic conditions. They were all associated with pre-frailty. And this really goes to show how important it is to continue to maintain frailty assessments and interventions well beyond the first year after transplant for our transplant survivors. And I think that's regardless of age. In another study shown by Sloan Kettering, this was Richard Lynn and colleagues at the MSKCC in New York City. They looked at geriatric vulnerabilities known as IADL or the instrumental activities of daily living impairments, and they supplemented that with age-adjusted HCTCI or the SORA score, as well as disease risk index. And these curves are from the univariate analysis, where the red curve is showing that it's when the IADL is not impaired, patients have better overall survival compared to that when the IADL is impaired. And on the right, again, you could see that the red line is quite separate from all the others that converge based on when the IADL is not impaired, combined with the low disease risk index. And this was further stratified even with non-relapse mortality, again showing that impaired instrumental activities of daily living had higher non-relapse mortality. This was even true when you combined it with age-adjusted HCTCI. And the only improvement in non-relapse mortality was if you had IADL not impaired. In another institute, the St. Louis University, they showed again feasibility of doing another rapid geriatric assessment scoring, where they use these very quick questionnaires, these 4 cohorts of screening for sarcopenia or loss of muscle. They also screen for fatigue, basic screening tool. Then they look for nutrition assessment, asking the patient some of these questions about appetite and food taste. And then a rapid cognition screen, almost like a mini mental exam, but this is even shorter. And they showed the feasibility of this approach, and it has you could reach them to get the scale at aging.slu.edu. So again, what I wanted to really show is that there are many different practices that different institutions are doing across the country, and there's no one standardized way in this heterogeneous approach to feasibility and frailty assessments. So that brought me to the question of how do physicians treating transplant patients and CAR-T patients in the United States feel about comprehensive geriatric assessment domains, and what are the intentions in terms of their practices if they want to test these patients. Because we know that there's increased benefit in doing these for our patients. We know that improves overall survival. We know from other studies in oncology led by Supriya Mohil, or the GAP study, and then other providers led the GAIN study, where they looked at geriatric assessment in the management of these patients, and in the toxicities of how they received these treatments, and they saw that they had bearing. And so why don't we use it officially in all our older patients coming to transplant? And so this manuscript is still in publication. It's hopefully will be there for your review soon. But what I saw is that most of these people who took the survey they were all physicians, And about at least 40% or so at minimum had a fair knowledge of the familiarity with comprehensive geriatric domains. That means that there is a gap in our education and in teaching us what are these domains, how can we use them. And interestingly enough, on the right, you can see the heterogeneous responses of the types of geriatric domains used in personal practice by the physicians who took the survey, ranging from MOCA, which is the mental health test and the screening tool, all the way from fall screen, a simplified frailty scale, the fried frailty exam, the modified fried frailty exam. There's various different scales that everybody is using. And in terms of when physicians would like to assess at what minimum age these geriatric assessments should be done, you could say that a majority of respondents considered 65 years as the minimum age to perform geriatric assessments for auto transplant, allo transplant, and CAR T-cell therapies. However, there are significant barriers still in performing these geriatric assessments, and these are, again, responses from the survey to show that time and resources are the leading barriers in performing this. But regardless, these are the ASCO guidelines, and they're very, very emphatic in saying that there is very strong evidence in that all patients with cancer, 65 years and older, with geriatric assessment identified impairments should have GA-guided management involved in their care plan. So not only are we doing, I feel, a disservice to our patients when we don't do our GA assessments, but all in all, when we do GA assessments and we find that the impairments, we really should cater personalized plans in order to get these patients the care they need and to have the appropriate outcomes. And so this is recommended by the ASCO guidelines. And so from the experts for transplantation, Richard, Lynn, and Andy Arts wrote this very nice review on how they approach older patient with heme malignancies for transplant. And they call this the ABCDEs of transplant referral. A for age, older than 60 to 75 or 75 years. A lot of times patients are not even referred because referring physicians feel that if they're 60 to 75, that they're too old. And so it's easy enough to just ask the transplant center, would you consider such a patient at your center for a transplant? And then B is to get a baseline function, if that is even adequate in order to get a transplant. Somebody who's sitting in a wheelchair is really not your ideal transplant candidate. And then management of comorbidities to make sure that all their diabetes, hypertension, all of that is well controlled. And then to get a disease risk evaluation for allotransplant and then early referral. And then to expedite that workup. So once they come to the transplant center, to really do a pre-transplant optimization, not only for their disease, but also for their resilience, which means that now you're doing your geriatric assessments and you're doing targeted interventions in the time between where you saw them for transplant and you're going to potentially consider them and take them for transplantation. You're also preparing their ecosystem, which is their psychosocial assessments. You're involving their caregivers and involving the mental health aspect of the care that they need. And then tailoring towards their particular individual plan and need. And so that's your final checklist that you complete, where you've controlled for the disease, you've accepted a suitable donor, you've determined that the patient is now resilient for transplant, and then finally to consider are there any clinical trials that they could benefit from. So that's really how they consider this formula of bringing somebody to transplant. And so how do we make the pieces fit? And I like to say, let's think broad initially. Let's certainly start with what we need to achieve at a global scale or even at an international or national scale. Let's start with what we'd like to do as guidelines in the United States. And maybe the EBMT comes up with their own personal guidelines for transplantation and geriatric assessments, where we really need to standardize the formula of what kind of domains we use for geriatric assessments by an expert panel of recommendations, where we need to involve stakeholders from patient advocacy groups, from the social workers, from psychiatrists, etc., to all sort of come in and pool in and talk about how we can test these patients for these problems. And then we need educational platforms for practical assessments and performance in the clinics. We need to have resources on how we can train our medical assistants, our physician assistants in performing these geriatric assessments. And then the next part of it is to integrate information technology and data collection systems into our electronic medical record system. And then finally into our CIBMTR forms to capture all that data as outcomes measures. And last but not the least is to have advocacy for reimbursement of these efforts, right? So I like to say, let's think big and make the puzzles fit on a large scale, but then we really need to make it fit to the individual need of the patient. And this is where you have to filter down to the individual patient need and go small, and which is the team approach. I like the acronym. I always love to use the acronym of Together Everyone Achieves More, where the inner circle really is that triad and interactions between the physician, the mid-levels, and the patient caregiver dyad, where everybody has to depend and co-depend on one another. And then from that inner circle, we depend on our ancillary support, where there's so much interaction between the social worker, the inpatient team with the patient and the physician, or our pre-transplant coordinators and nurses in getting these patients the screen that they need and their pre-transplant assessments. And then not to forget our educators and our research data quality managers to capture all the information in our, and think about patient-reported outcomes. And then finally, the larger circle, which is the entire social determinants of health and the network that keeps everything encompassed and allows us to have good transplant outcomes, which is the family support for their patients, their peers, friends, other support groups, through national support like the MDS Society, Leukemia Lymphoma Society, etc., church and spiritual aid if they have religious beliefs, and other community resources. So this is where I think we all need to sort of think about a dynamic model, but to individualize our care for our older patients. And with that, I'd like to stop and thank you for your attention. I'm happy to take questions, also leaving you with my email information for any questions or if you'd like to collaborate. Thank you.